Right, Shane, you can go ahead.
Wonderful. Thank you, Matt. So, good afternoon, everyone. Welcome to our department's citywide psychiatry grand rounds. For those I haven't had the pleasure to meet, I'm Shaheen Durrani, Director of Faculty Development and Mentorship in the Department of Psychiatry at the University of Toronto. Thank you so much for joining us today. Prior to the start of our session, I would like to begin with a land acknowledgement. Before I read it, please take a moment to situate yourself and think about the land under and around you. We recognize many Indigenous nations have long-standing relationships with the territories upon which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13 signed with the Mississaugas of the Credit and the Williams Treaty signed with multiple Mississaugas and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not. We're delighted today to have Dr. Amol Verma, physician and scientist in general internal medicine at St. Michael's Hospital, who co-founded and co-leads Gemini, Canada's largest hospital clinical data research network, present our department's Paul Garfinkel Distinguished Scholar Lecture on the topic of harnessing data analytics and artificial intelligence for quality improvement. Today's lecture is one of four named lectureships in our department honoring distinguished faculty. Dr. Paul Garfinkel, as we all know, had a renowned career serving as the former chair of our department and president and CEO of the Center for Addiction and Mental Health. The Q&A for Dr. Shaw's talk today, Verma's talk today, will be moderated by Dr. Tara Burra and Dr. Andrea Waddell, both psychiatrists in our department who have expertise in quality improvement. Please feel free to share your questions for Dr. Verma in the Q&A box. In support of continuously improving the quality of our citywide grand rounds, please complete the online evaluation that will be sent to you via a link from Eventbrite shortly after today's talk. Your feedback is very much appreciated so we know what went well and how we can improve to better meet your needs. And before I close, please save the date for our next citywide psychiatry rounds hosted by Women's College Hospital on Friday, January 30th, 2026, when our chair, Dr. Simone Vigod, and Dr. Benicio Frey will be talking about CAMET 2024 clinical practice guidelines for the management of perinatal mood, anxiety, and related disorders. Please also save the date for Don Wazelenki Education Day, being offered in person at the Chestnut Conference Center on January 29, 2026, an award-winning event, an annual conference that brings together faculty interested in increasing their knowledge and skills in teaching and education. We're very excited to have Dr. Adam Rodman, Director of AI Programs at Harvard Medical School, as our plenary speaker who will be talking about AI in medical education. We hope to see you there next year. So at this point, I'd like to turn it over and introduce Doctors Andrea Waddell and Tara Burra to give a few remarks and introduce our speaker.
Great, thank you, Shaheen. As the co-leads of the Psychiatry Quality Improvement and Safety Hub, we are really so pleased to have Dr. Verma join us today to inspire us about the potential for shared data and citywide collaboration, as well as artificial intelligence to improve the outcomes for our patients. Dr. Verma is a physician and scientist in general internal medicine at St. Michael's Hospital and the Temerty Professor of AI Research and Education in Medicine at the University of Toronto. Dr. Verma co-founded and co-leads Gemini, Canada's largest hospital clinical data research network, which is collecting data from more than 35 hospitals in Ontario who care for more than 60% of the province's population. Dr. Verma completed medical training at the University of Toronto, a master's degree at the University of Oxford as a Rhodes Scholar, and research fellowships through the Royal College of Physicians and Surgeons of Canada, the Canadian Frailty Network, and AMS Healthcare. He served on the Council of Canadian Academy's expert panel on health data sharing, is the provincial clinical lead for quality improvement in general internal medicine with Ontario Health, and is serving on the Canadian Institute of Health Information's Expert Advisory Group for Hospital Data Transformation and Ontario Health's Artificial Intelligence for Health Expert Advisory Group. He is the chair of the Researcher Council of the Digital Research Alliance of Canada and is a board member of DRAC and AMS Healthcare. Thank you so much for joining us today, Amol, and we are all excited to hear what you have to say.
Thank you so much for having me. And I would say, as the uh, participant list just ticks upwards here, I've become increasingly intimidated as a internal medicine interloper into the psychiatry world. I'm really grateful to be part of the conversation, and particularly a lecture that's named after Dr. Garfinkel. The conversation today, let me just make sure that my screen is being shared. Can you see my slides okay? Great. So, wanted to speak about harnessing AI responsibly in healthcare. At the outset, I'll disclose that we are going to speak. I have one slide to speak about an initiative that I co-invented, which was called ChartWatch. ChartWatch was sold by my hospital to a startup company called Signal One, for which I received a small minority interest in that company, less than 1%, and I have no direct relationship or ongoing with the company. I'm going to skip over the sort of typical learning objectives, but I think they've been circulated in advance and really just dive into it. So I think that when we talk about uh, artificial intelligence in healthcare, there are a couple of prevailing narratives, and I'll speak largely about AI and then a little bit about data and sharing and pivot to our experience. So, as the starting point, what I'd like to discuss in this lecture today is these prevailing narratives. So, the first prevailing narrative is that healthcare has been slow to adopt artificial intelligence. And the second is that we're on the cusp of astonishing change. And I'd like to ask whether we can believe those two things to be true. So, hopefully, by the end of today's lecture, we'll have answers to my opinion, and I would hopefully inform your own opinions about whether we've been slow to adopt AI and then whether we are really on the cusp of a really striking change. In order to answer that question, let's set ourselves a task, which is what clinical capabilities can we expect artificial intelligence to have? And let's just pick a window that seems reasonable to project forward. It's pretty unreasonable to project forward much beyond 3 years, where the scope of this technology is rapidly evolving and it's hard to know where we'll land. So let's say in the next 3 years, and let's set some ground rules for this exercise. So first is, if we're going to try to look forward and project forward over 3 years, let's look at where we are now, but also look at the trajectory of improvement. How have things changed over the last several years? That'll give us some clue as to how things might change going forward. I would commit to you to trying to give you no hype in this lecture. I'm trying to bring us a balanced perspective and really ground ourselves in the evidence. Um, I want to acknowledge that the conversation today comes from a high income country Canadian perspective. There are many clinical applications that may relate to global health or low and middle income countries, which we're not going to talk about. And I want to ground our conversation in capabilities that are based on widely available technologies, whether that be electronic health records, digital imaging, etc., not really cutting edge things like sort of robots, microchips, etc. So while some of the extraordinary advances to come down the road may come from those things, let's just take a really practical look. We'll look at clinical applications of AI from these perspectives. Okay, so let's ask the first question, which is today, what can AI do that is similar to what a clinician can do? if we're going to do that, let's ground ourselves into how we might evaluate a human clinician. So, some of you, when you're filling out your ITAR block evaluations, you might recognize that we would write something like this about an excellent resident. We might comment on their knowledge base, their communication skills, and their decision making. So, let's take those same three dimensions and apply them to AI today. So, we'll start with knowledge base. Okay, so this is a bit of an older study, but I put it up because it's one of the few studies I found that can actually show the trajectory of improvement. What you see on the y-axis is AI's performance on USMLE medical licensing exam questions. And on the x-axis, you see time. And then each of these alphabet soups are the different AI models that are being tested over time. And what we can clearly see is a initially linear trajectory, but then some pretty big step changes in the accuracy of response to USMLE questions over time. And I will note that December 22 is before ChatGPT exploded onto the public consciousness. It's right at that time. And so all of the advances we've seen in large language models over the last 2, 3 years actually happen after this. And so today's performance on this medical licensing exam questions is even much better. We're talking about 80%, maybe even sometimes achieving 90% accuracy on test taking. Now, one of the key uh, limitations when we think about AI's ability to respond to questions like this is, does that show that AI truly has medical knowledge, or has the AI simply memorized what's in like, has it simply seen these questions before? Because maybe these questions are part of their training data that these models were trained on. So, large language AI models have been basically trained on all the text available on the internet. I would ask you to reflect on what percentage of USMLE questions do you think are represented in some fashion on the internet? I would posit that almost all of them are available somewhere, whether it's in some chat room, some synthetic question bank, etc., right? So it's highly likely that these models have seen these questions before. So this was a study published in the New England Journal's AI journal, which we'll turn back to, not this, like that journal we'll come back to a few times in this talk. What they did was they took GPT-4, so that's about two generations older from today's GPT models, and GPT 3.5, and they applied it to Israeli licensing exams. These Israeli board exams were in Hebrew. They were never represented on the internet in a way that would have been readily accessible to the models. And I want to draw your attention to a couple of important points. So the red line here is the passing grade. The x-axis is the percentile among physicians taking the test. So you can see if we look, for example, at psychiatry in the bottom left-hand corner here, the model actually does, especially the blue model, which is GPT-4, does really well. It always passes, and it performs at the 70 to 80th percentile of all physicians taking the test. The y-axis is the number of attempts. So they took this model and they ran it 120 times on the same test. And so that's why you get these different bars. And so basically the GPT-4 model does really well in psychiatry. It does pretty well on gen surg and internal medicine, and slightly less well on pediatrics and not as well on obstetrics and gynecology. So what's the major takeaway is that these models are generally passing medical licensing exam questions consistently, but there is variability in performance across different specialties. I want to draw your attention to something that's particularly interesting. So these blue bars have a distribution. They're spread out. That's particularly interesting because what it means is, so what did they do? They gave the AI model, so it's the same AI model, GPT-4. They gave it the exact same questions and the exact same instructions, or prompts is the word that they would use to explain that. And what you see is the model performs differently on every run. And the reason it does that is large language models have a randomness that is part of their model production pipeline, so that they spit out different answers at different times. And this is done to enhance the creativity of the model, to enhance its expression and make it more, more interesting, basically. The problem is that's a pretty big departure from how we have been trained to think about the way computers interact with the world, right? Like when we think about computers, we think about stereotyped patterns of behavior where if you give the same computer the same set of instructions, it'll do the same thing. But it's kind of revolutionary to think about these AI models as not acting that way. They have a randomness, a stochasticity that is part of their performance. That means that they don't always respond to the same information or the same prompts in the same way. That poses really interesting challenges for the reliability of these technologies when we start using them in the real world. Okay, so we've talked about general knowledge and the important point, and I think while I've committed to you to not overhype things, I also do not want us to underhype things. We should allow ourselves to be appropriately impressed. And it is pretty impressive that there are models that can pass medical licensing exam questions. That's pretty exciting. Okay, what about clinical documentation? So AI scribes are perhaps the most well talked about and certainly the most widely deployed AI tool in clinical practice. It's an ambient listening device, might be on a phone, could be embedded on a laptop, basically listens to a clinical interaction and generates a clinical note out of that interaction, largely optimized for use in ambulatory settings. This was an Ontario-based evaluation of 150 primary care practitioners, and what they found was that primary care practitioners reported that they saved about 3 hours a week on their after-hours administration time in this study. Now, this was an observational before and after, and those that participated, you might imagine, are people who would self-select into wanting to be part of a pilot like this. Really hot off the presses. So literally this week on Wednesday, 2 randomized trials of ambient AI scribes were published. The first one randomized 238 physicians in the outpatient settings to 2 different AI scribes. One was called DAX. That's like a Microsoft solution embedded in, and I think they were both embedded in Epic, although I'm not 100% certain. And the second one was called Nabla. What they found was physicians that used Nabla in a randomized study had lower time in their notes by about 10%, but DAX did not improve time in their notes. Both scribes improved clinicians' scores on feeling burnt out or their workload. The second study randomized 66 physicians to something called a Bridge AI, a scribe that was embedded in the Epic's EMR system. What they found was that it reduced work outside of working hours by about half an hour per day, which is pretty consistent to what was reported in the Ontario study, if you sum that up over a week, where they found 3 hours a week. But what's really interesting is it was a highly skewed distribution where a small number of people had a huge benefit. And if you take away the top 3% of people who benefit, actually there's no statistically significant savings of time. So that's really interesting. So these savings seem to affect some people much more than others. And that's not that surprising when you think about how some of us spend much more time on our notes and others might spend much less. Some are much more fastidious about the way we document, etc. And so you can understand why there's a variable performance, but it's really important for us to then think about these technologies. They found, interestingly, that they did improve the billing code documentation, and they found that it reduced work exhaustion with these scribes. So I think the takeaway on these scribe technologies is that they are a reasonable, very low risk tool that seems to make clinicians feel better, like less burnout with using them, which is amazing given the state of our healthcare system. But they're not really driving that much efficiency gain at this point. I think where people are optimistic that they might is when it embeds into the technology A, billing practices, B, ordering of investigations, C, delivery of prescriptions, right? So once all of those things are embedded into the technologies, the hope is that that will then be a true productivity tool. The risk, I think, in our Canadian system in particular, is that we know that our IT systems are much more fragmented than a lot of the American systems where these things are being tested. And so I'm a little bit less confident in my context where whether my prescription gets received by my pharmacy from my family doctor, I would say is like a 15% hit rate right now because of the fragmentation of our IT systems. Like the likelihood that the AI agent is going to be able to do that automatically, there's a lot of like core interoperability and IT system problem here in our country that may mean that that is work that it takes some time to get to. I am optimistic that on a 3-year time frame, which is what I committed we would look at, we will have these ambient scribes that have a lot of those functionalities embedded. And for at least a meaningful proportion of the time, it's not going to be 100%, but may make it easier to do those downstream things, especially things like billing, et cetera, so that they can really become productivity enhancers. I will say that in our public healthcare system, I think we do have to ask, how much does this cost? And are these savings worth the money that we're going to spend on them? And, I have yet to see a really good economic evaluation around these. Okay. What about summarizing information from an electronic health record? So can it generate a discharge summary, for example? So one study in urology clinics found that AI could produce resident level discharge summaries. Another study in ICU patients found that about 80%, that discharge summaries had about 80% accuracy, but 14% contained something called a hallucination, which is the model just makes something up. It sounds very plausible, but it is not real. And that's been historically a real limitation to the use of these large language models. And I'll turn back to that in a second. The study that is the most relevant to this audience. So this was a study of psychiatric inpatients. They looked at discharge summaries. They had staff physicians rank the discharge summaries or rate the discharge summaries produced by residents and produced by AI. What they found was that resident summaries were deemed to be good or favorable in about 67% of the time, whereas the AI summaries were good only about 22% of the time. And the big gap was hallucinations, where 40% of the AI summaries, again, included information that just did not happen. Now, hallucinations were historically a very big problem, particularly with the earlier large language models. It's a problem that's getting much better, and it's getting better through a variety of different technological fixes. One fix is something called retrieval augmented generation, which is that you force the AI model to only generate information that it has retrieved. And so you can say, okay, you have to go into the record, retrieve a piece of information, and then generate it. And by doing so, you can reduce the amount of hallucination. I will say, projecting forward, I feel reasonably confident that hallucination will be a problem that's largely overcome by different technological solutions. And the reason I feel confident in that is if you think about where these AI technologies are being developed the most, it is Silicon Valley and it is internet search. And the key thing about internet search is that it has to point you to a real website. And so it can't hallucinate. So these companies, Google in particular, is very highly incentivized to create tools that will not hallucinate. And so the likelihood that we will have technologies that will hallucinate less, we've already seen it. Like the latest models are much less likely to hallucinate. So projecting forward, I think it's very clear that summarization of electronic health records is a task that these tools are going to be very good at and could hopefully help complement the amount of work that goes in to those kinds of tasks. Okay, so pivoting a little bit to talk about a study called Amy, published by Google Research. This was probably the splashiest health AI publication of the last year. Google Research developed something that they called the Articulate Medical Intelligence Explorer, or AMI. Essentially, they trained AI models not just on all of the previous evidence I was talking to you about are general purpose AI models. They were models that were not specifically trained on clinical interactions. Amy was trained, starting point was those general purpose AI models, and then it was further trained on clinical interactions, clinical notes, synthetic patient cases, etc. They then took Amy and they did a randomized study in a virtual OSCE setting. So what they did was they had a simulated patient. The simulated patient came to a text chat conversation, and on the other end of it was either a physician or the AI, and the patient was blinded to that. And they had a native text conversation. There was no prompting. There was no like the simulated patient did not give a stem for the OSCE, etc. It was literally just a hi, how are you, and get started with the chat. And then they evaluated the transcripts of those interactions. The patients self-rated, and they had external physicians read and rate. And so what you can see here on this slide is AI is red, physicians are blue. It was on an ordinal scale, so the darker it is, the farther to the right, the better the score was. And so what you can see is that the AI was more polite than physicians. It was better at making the patient feel at ease. It was better at quote unquote listening to the patient, whatever that means for an AI model. It was better at explaining the condition. It was better at involving patients in treatment decisions, and better at appearing honest and trustworthy. So across a range of these tasks, AI was better. And what's really interesting to me is I think if 5 years ago you had asked someone in healthcare, what will AI be good at? What will it not be good at? We would have said AI will be very good at medical knowledge, right? It'll have an excellent memory retrieval and etc., but it won't be as good at being empathetic. Well, it turns out that these language models are amazing at appearing empathetic. So that was talking about the ability to communicate, right? We talked about AI scribe documentation. We talked about summarizing notes. We talked about communicating in live conversation with patients. Now, if we pivot to talking about diagnosis and decision making, the same Amy study, how often was Amy able to achieve the right diagnosis? So the x-axis here is the number of guesses the physician or the AI model was allowed, and the y-axis is the accuracy in getting the right diagnosis for the case. Remembering these are simulated environments, so we know what the diagnosis is. So on every guess, like if they have one guess, AI gets it right 77% and the doctor is 65%. And all the way across, AI is better than doctors at making the diagnosis. So I think this is where we should pause and allow ourselves to be wowed. This is amazing. It is amazing that an AI model could interact with a patient with no additional prompts, just like in a free text-based conversation, and could appear to be as empathetic as a clinician and could be better at diagnostic decision making. That's amazing. The important no hype caveat to all of that is I ask you to reflect as a clinician, those who are clinicians in the audience, how often is your interaction with the patient a text-based conversation? Very rarely, I would suggest. And really important ways for humans to show empathy are through things like eye contact and tone of voice, and sometimes even touch. And very important to diagnostic decision making is that same set of inputs. How does someone look? How do they sound? All of those pieces of information is a core part of our clinical training. So we cannot walk away from this study and say AI is better than doctors at anything. That is not what we should take away. But I think what we should take away is it's pretty extraordinary how well AI can interact with people in natural language. And if any of you have interacted with some voice agents now, they can have a very human sounding conversation in a way that's really striking. And so how do we take advantage of that technology to make clinical care better? Okay. Here's another sort of caveat around that. So this was a great study published recently in the New England Journal's AI Journal by one of our actual former trainees in Toronto, Liam McCoy. They did something called script concordance testing. So again, I love that we're taking these approaches from medical education and applying them. So the previous study was in OSCE. This is one where you have a clinical scenario, but then you change the scenario. You add new information. So you say that, you tried this treatment and the patient had this response. And then see how does the model update its performance in response to new information. They compared 10 state-of-the-art AI models, large language models, to 1,070 medical students, almost 200 residents, and 300 attending physicians. What they found was that the models performed worse with new information. They could all match medical students, but they could not perform as well as residents or attending physicians. And so I think this highlights an important limitation of the AI literature, which is that a lot of it is in these synthetic snapshot environments rather than the complex and dynamic changing environments that we really practice in. So we have to be really careful about extrapolating capabilities from these settings into real world contexts. Okay, so to summarize on the clinical knowledge, it's pretty clear that AI has a growing ability to encode real knowledge, not just questions it's seen before. The knowledge base is inconsistent across specialties. It can synthesize and communicate medical information in natural language, but still limited by accuracy, and has improving performance in diagnosis and management plans, although challenges remain with changes over time. So that was all about AI acting like clinicians. What about AI complementing clinical decisions? So this was a project that my team led, where we developed an AI model that could take data in the electronic health record and predict patient deterioration for hospitalized medical patients. So it could predict which patients end up dying or needing ICU on their hospital stay. What we found was that both clinicians and the model had pretty similar predictions. So they were both of similar accuracy at predicting this outcome event, talking about physicians and nurses as they care for their patients. But what's really striking is that we predict different cohorts of patients. So the physicians and the nurses identified a subset of patients, the model identified a separate subset of patients, and when you combine our predictions, you actually get better predictions. So you can identify 16% more deterioration events with no more false positives. What that means is when we train our clinicians to interact with this model, we tell them, if you have a hunch that a patient is going to deteriorate, but the model disagrees with you, follow your own hunch. If the model has a signal that the patient is going to deteriorate, follow the model. So always default to following the highest risk signal, and that way we can actually identify more patients and intervene. We then took this model and deployed it on our medical unit at St. Michael's, and what we found was that implementing the early warning system was associated with a 26% reduction in non-palliative mortality on the units that used the model, and with no change on units that did not use the model. So this is exciting as an opportunity to complement and support clinical decisions. This is, to my knowledge, the largest randomized trial of an AI intervention. It was done in Sweden. They took 80,000 women who were getting mammograms, and they compared screening with and without AI support. The AI support looks like this very simple thing on this slide where it's a little circle highlighting a lesion that could be cancerous. What they found was that the AI model led to a 44% reduction in radiologist screen time and better cancer detection with no more false positives. That's extraordinary. The no hype caveat to this study is that the reason there was such a massive reduction in radiologist screen reading time is that in Sweden, 2 radiologists read every mammogram. They do that because it's a tedious job and it's easy to make human errors. So they double check. They get 2 independent reads. So what they did with this study was they used AI to do the second read, and only when it flagged a problem did they have a second human read it. So that's how they were able to gain so much efficiency. Well, in Canada, we do not have 2 readers of every mammogram. And so we would not be able to benefit from this efficiency gain in our system. Okay, and then a last sort of scenario of what can AI do that clinicians can't. So this is an ECG in normal sinus rhythm. This is an ECG in atrial fibrillation. Most clinicians can see the difference between those two things, and it's very easy for AI to distinguish normal sinus rhythm from atrial fibrillation. That's straightforward. What's more interesting and kind of revolutionary is that AI can look at an ECG when a patient is in normal sinus rhythm and predict which ones are going to end up in atrial fibrillation. And I don't know of any human who can do that. So this was a study conducted out of the Mayo Clinic where they applied AI to all of these patients who have high cardiovascular risk in normal sinus rhythm, and they were able to identify those who develop atrial fibrillation. Those who develop atrial fibrillation can be anticoagulated to prevent the risk of stroke, And what's really nice about a technology like this is it lets us identify those patients and potentially intervene on people who have silent AFib before they have a stroke. And so they conducted a prospective study of people who would be eligible to be anticoagulated and found that the AI algorithm tripled the detection of atrial fibrillation over 10 months. And so they're now, looking forward to seeing the next step of this, which is, are they able to actually prevent strokes? But it's an extraordinary example of where we can start to use AI to do stuff that humans could never do. Okay, so to kind of conclude this section of the lecture, what can we expect AI to accomplish in the next 3 years? One, it can act like clinicians. I think it's reasonable to expect information processing and document generation, at least at the level of a competent trainee over the coming years. Okay, so what does that mean for our clinical practice? How do we design to start using these tools to make, enhance capacity and improve the quality of care? The second is it can complement decisions. How do we incorporate this into practice to support, as we do with all sorts of decision support tools, right? And then the final thing is perhaps the most revolutionary. It can do things that we can't. How do we incorporate that without having too many false positives, without over testing, over treating, etc.? So these are, I think, the exciting questions for us to grapple with in the coming years. No hype, performance is imperfect, and the evidence that I've told you is largely preliminary. A handful of good quality randomized trials. Other than that, it's mostly observational evidence. What are the critical limitations? So one major gap is we are not doing enough clinical trials about AI. So between 2018 and 2023, this is a scoping review of every clinical trial done of an AI tool across the world. During this time, there were 100,000 randomized trials of medications. There were only 86 of AI interventions, and of those, only one happened in Canada. I think we really need to apply the same standards of evidence we do to other medical interventions to our clinical facing AI interventions. Because as you could see, there was actually really important insights even in that AI scribe difference, where the observational study suggests on average 3 hours benefit for physicians. When you move to the randomized trial, you find that actually it's a small number of clinicians that are benefiting. And so it really changes, I think, the way, and it doesn't work for all of the different AI scribes. Some worked, some didn't. So it really changes, I think, the way we think about it. And the second critical limitation is the use of real world data. So this was a systematic review of 520 clinical studies of large language models. Only 5% used real patient data. The vast majority are using these kinds of synthetic games, like I talked to you about, those OSCE scenarios, USMLE exams, etc. We know that the real world setting has so much more imperfection in the data, colloquialisms, differences in the way we use language, and importantly, often doesn't have like a simple answer at the other end of the clinical scenario. We don't always know what the diagnosis is, etc. So before we get wildly optimistic about deploying all of these technologies, I think we really have to up our game on the standards of evidence that we insist on. And I will say that because there is a massive financial incentive around these technologies, very similar to the financial incentives around pharma and devices and other, industry, that it is very important for healthcare to work with to bring new technologies forward. We need to insist on those same standards of evidence, the same approach to calculating health technology assessments and assessing returns on investment. Otherwise, I am very worried that we are going to spend billions of dollars on these novel, shiny AI solutions that may or may not actually be improving care and in some cases may harm things. So how do we do that? How do we develop and test clinical AI? Well, you need three things. You need data, you need computing infrastructure, and you need people. Those people have to be the end users of the data, of the solutions, but they also need to be data scientists. And importantly, we need a multidisciplinary approach to evaluating these technologies. We need ethicists, we need social scientists, we need anthropologists to understand how behavior changes and how these technologies should be evaluated appropriately. So that's the work we're trying to do with the platform that I lead in Ontario called Gemini. So Dr. Fahad Razak and I co-lead this network of now about 40 hospitals across Ontario, which share electronic health records data for adult and pediatric patients. And we hold about 3 million hospitalized visits of data. We put that together in a high-performance computing environment that enables machine learning and other computationally intensive uh, analysis. And then we make those data available. We make them available to scientists, students, clinicians. The platform has supported more than 150 projects and has been a real resource for investigators to raise grants off of it, most of which are held outside of my institution. So, really delighted that this is a system resource increasingly. One of the ways that we use our data, this is a bit of a pivot from AI, and I'm going to try to wrap up in about 3 minutes or so here, is we use the data for just quality measurement and quality improvement and sharing the data across our hospitals. So what happens is we take all of the data we receive and we turn them into physician practice reports. So each physician who's practicing internal medicine or hospital family medicine, hospital medicine, they receive a report that looks like this, that tells them about their care for things like medication prescribing, hospital length of stay, readmission, imaging tests, etc. And compares it to their colleagues, and then they can have a conversation about opportunities for improvement. We also provide hospitals with a benchmarking report that tells them about the quality of care they are providing and where they have an opportunity to improve compared to other hospitals in the network. And this is an early evaluation, which I'm excited to share with you around some of the improvement that we've seen. So, what you see here on the y-axis is average hospital length of stay. The x-axis is time in months. Time zero here with this blue line is when hospitals received their first quality report from GEMQuinn, from our general medicine QI network. Those reports were staggered across various months across 2022 to 2023, creating a natural experiment. So it's not just one time point. And what you see here are three lines. The lines are based on the hospital's own length of stay on their first report. So the red were the hospitals with the highest length of stay, green was average, and blue were the top performers with the lowest length of stay. What you can see is the top performers stayed top performers, and the average and the outlier bottom performers got better. They got better by learning from other sites. We heard about hospitals sending teams to other hospitals to learn, and that this created a meaningful performance gain across the system. So we saved about 0.3 bed days per admission. That's roughly a 5 to 7% reduction in hospital length of stay, which aggregated across the tens of thousands of GIM admissions leads to 50,000 bed days saved, which is about $55 to $60 million of avoided cost in the healthcare system. It just speaks to the power of sharing data and working together as a community. So I think I was gonna speak a little bit, but in the interest of time, what I'll just say is we are using Gemini to do work now on creating prediction tools that we can then scale across the system. So we've created an algorithm that can predict delirium at the time a patient is admitted to hospital. And then we're rolling that out in a 12 hospital randomized trial coupled with quality improvement interventions where we try to prevent delirium in the highest risk patients using evidence-based bundles that have been very difficult to implement. But our hope is that implementing them just for the highest risk patients will be feasible. The problem is they're very labor intensive and it's hard to implement at scale across whole hospitals. We're rolling this out in a 12 hospital clinical trial of 15,000 patients. It'll be the largest AI trial in Canada, to my knowledge to date, and really excited about doing that in collaboration with sites all across the city, including with CAMH on the mental health side. And that's a big area of work is trying to move out of the medical side alone to start thinking about more broadly acute care. I'm going to close with one thought. So I'm skipping over some of these sides. So for Canada to compete globally, when we think about generating science and improving our healthcare system using AI technologies, it's clear that we cannot outspend countries like the United States, the Middle Eastern countries, even Europe, who are investing hundreds of billions of dollars. But what we can do is lean on our very serious advantages. So the first is that we have the best data in the world for healthcare because we have an inclusive single-payer healthcare system in the most ethnically diverse high-income jurisdiction in the world. And now Canada is not small. We have 40 million people. So that can allow us to create more generalizable and precise science. We have world-class scientists. We have some of the best clinical trialists in the world, and we have some of the best AI scientists in the world. So combining that science, as well as I talked about, that multidisciplinary approach to doing science is a massive advantage in Canada. We are good at collaborating in a way that other countries are maybe not as good. And then it's really important for us to think about creating Canadian AI solutions and the capacity to test foreign AI solutions before they're used in Canada to protect the sovereignty of our healthcare system. So in order to do that, I'm really excited to share that our team has started to build something called the Vital Data Platform with funding from the federal government. So this is bringing together near real-time hospital data from 20 million Canadians across Ontario, Alberta, and Quebec into one space for research and innovation. So we received an initial investment to bring this together, essentially to build the infrastructure to create this platform. And really excited to try to put Canada, make it easier for us to do this kind of research, this kind of clinical trials in particular, and evaluations of AI technologies, so that we can benefit from this extraordinary opportunity. So to come to that closing thought, I do not think healthcare has been slow to adopt AI. I do think we're on the cusp of astonishing change. But I think that we have been slow to rigorously evaluate clinical AI tools in real world settings for effectiveness, equity, safety, and cost. And it's imperative that we move to do so really urgently. And I'm really excited to be part of the work, the teams that are working on this. And I hope you'll agree with me that there's an extraordinary opportunity to do that. So thank you so much for the opportunity to speak with you, and really keen to take questions.
So thank you so much, Dr. Verma, for this excellent presentation, reviewing how to harness data, analytics, and AI for quality improvement, as well as improvement in health practitioner well-being. I will now turn it over to Doctors Burra and Waddell to moderate the Q&A and invite questions from our audience for Dr. Verma into the Q&A box.
Thank you so much, Dr. Verma. I'm just going to kick things off. So thank you for summarizing the evidence to date on the use of AI scribes and the potential for efficiencies and reducing burnout. I wonder if you could comment on the AI tool specifically for patients and patient experience, and patients bringing AI tools into clinical interactions.
Yeah, so on the patients bringing AI tools to clinical interactions, I think we're seeing that increasingly. I'm sure many are seeing it in their practice. Just like we saw with the rise of the internet and people, Dr. Google or whatever, right? We're now seeing Dr. ChatGPT. I will say that these AI models are reasonably good at surfacing information. And so I think it gives us an opportunity to have a conversation with patients in a similar way as to, them having been informed before. And so I hope that we continue to I just see it as on the spectrum of the continued kind of empowerment of patients with all the same foibles that we had before. We sometimes need to check the information, and hopefully in an ideal world we create the space where people come to their clinicians to ask those questions. But recognizing that increasingly people are just using ChatGPT, and obviously there's lots of problems. I don't need to tell this community all of the problems with particularly related to mental health and the use of these AI chatbots. I purposefully left that out of this conversation where I focused on really clinical facing AI applications. But yeah, lots of concern about the harms of using those tools as well. In terms of patient experience, I have seen a bunch of different interesting things. So one is we receive a lot of narrative patient experience information that is sometimes hard for healthcare organizations to parse the large volume of that information. So I've seen some organizations using AI to pull out themes that they can react to, and I think that that's an exciting opportunity. I also think, just again, analogous to this idea of the patient empowerment interaction, like having chatbots that can elicit more native language, like natural language feedback, I think is an opportunity that we should be exploring for sure. So yeah, totally agree.
Thanks very much. On along the lines of that, of like understanding the nuances of discussion, there's a question about how AI would handle scenarios in which patients are providing sort of inaccurate information, things like delusions or factitious or malingering presentations. Often physicians can notice these inconsistencies between the content and what patients say and how they present. And the question is like, how well does AI do that?
That's such a great question. I have never seen an evaluation. I mean, I'm not so deep in the psychiatry AI literature, but I have not seen an evaluation looking at that specifically. What I would say is that none of these AI tools are autonomous. They are all purposefully intended to be used with clinician reviewing, editing, and then adding their notes to the medical record. And so my assumption is that the way that would work is that the AI scribe would report what the patient said, like that would be part of the note, and then the clinician would have to go in, edit, and make that change. And I do think that that's that's the way that that is being handled currently, which is sort of the human in the loop approach to it.
We had a question going back to the example of screening for AFib and having an algorithm that involves AI. And so just wondering if you could comment a little bit more on that.
Yeah, I think the comment is getting at the explainability of AI tools. So like the idea of an algorithm, I guess, is that it's pretty you can follow the logic of an algorithm, right? You can kind of see step by step. Whereas many AI solutions are black boxes, particularly as they're so black boxes meaning that we don't, it's something goes in and then something comes out, and it's hard to know how it arrived at the production of that problem. And I would agree with that. I would say that there is a lot of work happening on the explainability of different AI algorithms, pros and cons of that. You can basically train a model that tells you how the first model worked. And there are some AI tools that are inherently explainable. So, like, for example, our delirium prediction tool that we've developed is a machine learning model that actually is designed to be predictable. And you can see the 10 predictors or 15 predictors that go into the model and understand how it's making its decisions. So, there's a mix of approaches there. But the point about the black box nature, I think, speaks directly to my call for better evaluation of these technologies across different settings, which is that just because something worked well somewhere doesn't mean it's going to work well in our environment. And so I think that requires two things. One is multi-center, high-quality randomized evaluations of these technologies. But secondly, actually local testing and validation before we use something to make sure it works well locally. When you have a low-risk thing like an AI scribing technology where clinicians are reading the output every time and editing it as needed, the harm is basically just that the tool doesn't work well, and then you get really quick feedback, right? Like the clinicians say this is not useful, and then it gets thrown out, right? So I think that's more straightforward. But when you're starting to make decisions like triaging decisions or other things where the harm is less easy to see and get that immediate feedback, it's where we have to be really careful about doing those kinds of evaluations.
Great. I think Dr. Bigod, who's the chair of the department, has a question for you.
I do. Thank you so much. This was really incredible, and I think you've tapped into, an area that is of so much interest in our department. So I'm going to get granular because you're local, so you like you have our context. And I think a lot in psychiatry about um, how, we have a lot of ambulatory patients and a large majority of the kind of mental health burden in this country is ambulatory. And we have all sorts of sort of smatterings of different ways that we look at clinical outcomes and maybe not like a systematic data infrastructure in the same way as you can measure someone's, heart rate or blood pressure in an ICU. And we've been talking a lot in our department about how do we build learning health systems, and what kind of data and people infrastructure we need to do that to make almost like an outpatient Gemini for mental health. And I'm just curious, you know, what you think about that. Where, like, when you look at us, where do you see where we are on the path, and what would your recommendations be? Is that too much, Amol?
No, no, it's a great, thanks for having me, and thanks for the great question. First, I will say I would never come to a psychiatry grand rounds and tell the psychiatrist what I think about psychiatry. That would be crazy. No, but I think your point is so well taken and applies, I think, importantly to a lot of patient important outcomes across the spectrum of healthcare, right? Like, so the problem, of course, with most data-driven and AI-driven solutions is that they tend to orient around stuff that's easy to measure, which when we then talk about, what we value in healthcare, there's a pretty big gap between what most of us would say is important about the healthcare we receive and what's easy to measure, right? Like, so whether it's how we feel or like these different important aspects of our mental health, but also like how we were we treated with dignity and respect, all this other stuff. Like, so I could not agree more. And I think the um, uh, actually solutions that come out of the psychiatry space will have a huge relevance for everywhere else too, right? So I guess I'm aware of two thought processes that might make sense. So one is, and I think this has historically been the way we've approached these things, which is we try to embed standardized approaches to measuring outcomes, et cetera, like this measurement-based care movement, so that we can have the same scales or the same things embedded everywhere. And I'm like, I don't know, moderately optimistic around that approach because I do think it makes sense and there's like, you can have some reasonable consensus. But like the reality is those things are often very time consuming to measure or people have different opinions about what they want to use. I see someone put in the chat the Interride tools. That's like a perfect example of like some standardized approach. But I think actually one exciting opportunity for AI is to say, could we take an ambient scribe? And could one of the things about that ambient scribe be not just spit out a narrative, but like populate a tool based on the conversation we had? And could we validate that, the ability of doing that? So like a study that said, hey, you can take a depression inventory scale and you can say, how well can the AI scribe just do that without forcing us to answer those questions and then actually have the patient fill it out and then validate and see. Like, I think there could be extraordinary opportunity for us to use AI from natural language to try to do some of that measurement for us as well. And I would love to see the field go in that direction with like the appropriate validation testing to see how well that works, right?
Wonderful. Thank you so much, Dr. Verma, for your superb presentation reviewing how people, data, analytics, and artificial intelligence can be brought together to support quality improvement. I don't know if you can see, but there's lots of positive feedback in the chat from our department faculty. We're very grateful for your vision, your advocacy, and leadership in healthcare improvement. So thank you so much, as well to our moderators, Doctors Burra and Waddell, our support team, Anastasia and Matt, for your help behind the scenes for today's rounds. And finally, thank you to our attendees for joining today's session and for your engagement and participation in the Q&A. I know there were lots of questions that we didn't get to, so we'll definitely have to bring you back again for another rounds, Dr. Verma. We look forward to seeing everyone at Don Wazelenki Education Day on January 29th, as well as looking forward to seeing everyone at our next citywide psychiatry grand rounds on January 30th, 2026. So until we come back together in the new year, I wish you all a very happy holidays. Enjoy the rest of your day, everyone.